Hi, everyone. This is Serge Korjian coming to you live from ACC 2024, and I'm honored today to be joined by the one and only Dr. Mike Gibson to discuss the long-awaited results of the AEGIS-II trial. Mike, welcome, and thank you for talking to us.
This is odd. I'm usually on the other side of this whole thing, but thanks, Serge. Well, we all know that high HDL is associated with good outcomes. And there were many efforts over the years to raise HDL to improve outcomes. A lot of those efforts fell short. I think there's a few reasons. One was there was off-target toxicity. People's blood pressures went up or their CRP went up that eroded the potential benefit. And then the goal was to raise the number of HDL particles, but maybe those particles weren't really good cholesterol. Maybe they were okay cholesterol. They didn't function as well as they should. So we have been working on testing people's blood and seeing how good the HDL is. How good is its function? And it turns out that people who have poorly functioning HDL, they have bad outcomes. And the people who have really good functioning HDL can efflux cholesterol from their macrophages, have good outcomes. Now, in the setting of a heart attack, this is very important. People who can't efflux cholesterol, who have poorly functioning HDL, have worse outcomes in the first 30 days. So, what if we gave something that was human based, not a drug? What if it improved the efflux of cholesterol out of those cells in a heart attack? And that's what we tested human ApoA-I right after a heart attack to see if we could improve outcomes. We randomized people who were high risk, they had multivessel disease and some risk factors, and we gave them 4 weekly infusions of human ApoA-I or matching placebo. Our primary endpoint was at 90 days. We thought this was an acute problem. We'd see an acute advantage. We did not see a statistically significant reduction. A numeric reduction was there, but it didn't achieve statistical significance. A little bit to our surprise, I have to say, the curves continued to diverge, and we did see a trend towards a reduction of P of 0.076 in the primary endpoint at 180 days. Now, when you do a multiple event analysis, that p-value is 0.04 at 180 days and at 1 year. So the burden of disease for the primary endpoint seemed to be reduced. When you drill down into things, there was nothing in terms of benefit for stroke. There was nothing in terms of benefit for type 2 MIs. But for the other MIs, type 1 MI, type 4 MI, stent thrombosis, we did surprisingly see a benefit. And Serge, you're the lead author on the MI paper. And when you put cardiovascular death and MI together, yes, we see some benefits. Now, I think when you go to exploratory endpoints that are hypothesis generating, we looked at people who had hyperlipidemia at baseline. And you can look at it as a continuous variable. The higher the LDL, the greater the treatment effect. But just out of, from 2004 guidelines, I picked a number of an LDL of 100. And if you were above an LDL of 100, you had a 36% reduction in death and MI. And that was a 2% absolute risk reduction, meaning you had a number needed to treat of 50. The interaction p-value was positive, meaning that LDL modulates the treatment effect of HDL. Now, if you had an LDL below 100, there was absolutely positively nothing there. The curves were superimposable, superimposable. So, we're learning a lot about the HDL hypothesis. I think looking at the totality of the data, I think all of us as co-investigators, the steering committee of 35, concluded that we unanimously feel that the hypothesis is supported, that HDL does play some role in plaque stabilization in coronary MI. I think it makes sense if you have no garbage floating around in your bloodstream, you don't need garbage trucks. But if your LDL is below 100 and you have some garbage, you need perhaps some garbage trucks. So the findings should be taken as exploratory on the LDL side, but are biologically plausible and lend again credence to the HDL hypothesis. So we're in the midst of digesting all this information to figure out, what might be a good path forward.
Excellent. Like, I think there's a lot of information here that helps support the HDL hypothesis, but also contributes to the science of understanding how HDL actually functions in the human body. So thank you so much for this work, and thank you so much for joining us to talk about this trial.
Thanks, Serge. Thanks for having me.
And thanks to all of you for watching. Stay tuned for more videos from ACC 2024.